Hello, everybody, and welcome to the wrap-up interview on CTO. It's a great pleasure and an honor to be co-moderating this interview with Dr. An, and also have distinguished friends and collaborators for years, expert CTO operators and researchers, Gerald, Werner from Germany, Paul Kao from Taiwan, and Kambis Mashayekhi from Germany. So there's been a lot of debate during this meeting, and I would like to start with like an open question for everybody. How do you decide when a CTO should be treated by PCI? And then we can elaborate further on how the Revive and ischemia trial might have affected your practice. But Kambis, how do you decide when to treat a CTO?
Well, first of all, Dimitri, when I think about revascularization, I don't care if there is a CTO or not CTO. I'm thinking functional in terms of is there ischemia or not. And so basically probably more like a surgeon's standpoint of view. And after it comes to the decision to do PCI, so I'm more focusing on who is going to treat the lesion. Because there's a huge variety of operators. So probably here we did all together probably more than 20,000 CTO PCIs. So, and I think that has to be included in our decision making. So yes, can I do a CTO in a very safe manner? I'm sure I can. Is the complication rate low? Yes, it is, but it won't not be probably for somebody who starts with this procedure.
That's a very insightful comment. Paul, do you treat just for symptoms, or do you factor ischemia burden? And I'm asking you in the recent context and controversy about what is at the end of the day that kills you. Is it the ischemia or is it the MIs and the events?
Sure.
So asymptomatic, large territory, young guy, ostial LAD, just as we debated before. Tell me a little bit about your thought process.
I think we should treat any CTO just like any other patient with stable coronary artery disease. CTO should not be singled out simply because it's a CTO. We should treat the patient the same. So I'm always looking for clinical symptoms. I'm always looking for objective signs or evidence for ischemia, and especially the burden of it. And also I'm looking at left ventricular function. And other minor considerations would be age and the patient's frailty and his general daily activity. Let's say if you have a very senile patient who is not doing too much of activity, then maybe we'll be more conservative. But on the other hand, if you have a 40, 50 proximal LAD CTO with 15% of myocardial burden, even though he said he denied that he had any symptoms, but I will still consider very seriously in opening up this CTO. So I think it's not that every CTO should be open, but we should treat any CTO like any other stable coronary artery disease patient.
So let me challenge you a little bit here. So you have an 80% ostial LAD, like an orbiter patient.
Yeah.
Would you stent that patient?
Well,
up front, or would you do the orbiter thing? You're going to start poisoning with medications and waiting and doing repeat stress tests and be on the phone 24/7 with with all the patients.
To be honest, I would treat the patient as a physician, so I put him on drug first. But most of the time, even though you are on guideline, but the patient will still be symptomatic or have evidence for myocardial ischemia. That's the time we as an interventionist then step in. Otherwise, before we are interventionists, we are all physicians. Mm-hmm. So that is my philosophy.
Very wise answer. Yeah. Gerald, good old friend of mine. We go back how many years since I started doing CTO PCI? You were already in the field. So you've been in the field from the beginning, pretty much, right? You were involved in CTO PCI for many, many years. And you had your own great publications. We learned a lot about collaterals from you and the Euro CTO. If you can share with us 3 or 4 major breakthroughs or a couple of occasions that you think were interesting throughout the years, that would be very useful for us and the younger generation of interventionalists.
Well, thank you, Dimitri, for this question. and the introduction, which makes me feel really even older than I am.
No, it's respected.
Nevertheless, the field of CTO PCI is older than I know, because it was this famous interview of Grünzig, who realized that if we cannot treat chronic occlusions, we cannot treat multivessel disease. But at that time,
And the first stent ever used was used for a CTO.
Yeah.
But anyways,
and so, but the major breakthrough for CTO PCI, in my view, and really made it interesting to a broader audience or group of interventionists, were drug-eluting stents. Because before, balloon angioplasty, bare metal stents, we failed to keep the artery open. And the lesions at that time were not comparable to the lesions that we see today. So probably the reocclusion rate would be 50%. So drug-eluting stent introduction, I think, made the field a field to pursue, because now the challenge was not to keep it open, but to open it. So the second major breakthrough certainly was the introduction of the retrograde approach for the very complex lesions, osteal lesions. And third, I think learning to include imaging, most on-site IVUS, but also CT,
pre-procedural planning.
Into the concept, strategic planning of CTO PCI. These would be my three major steps that I see that brought us forward. Along that came, of course, technical innovations, wires, microcatheters, which is continuing. And I think the fourth thing that is left is the challenge of calcium. And also there we see progress with introduction of new therapies, lithoplasty, whatever, and maybe we can at one point direct the calcium destroying therapy forward, and that would break through what is still the obstacle.
Thank you, Gerald. Dr. An, who should be performing CTO PCI? And not only as far as operator is concerned, but the center. There is a concept, at least in the US or some of us, that we should treat PCI centers the same way we treat trauma centers. They should be level 1, level 2, level 3. So the most difficult and serious cases should be go to level 1 trauma. Is this a concept that you agree with? Do you think that everybody should be performing CTO PCI and every hospital, or should it be somehow organized in a way with satellites and referral patterns?
Dimitri, this is a very important questions. Not only in the field of CTO, but also whole PCI society. I think particularly the complex PCI case, because the operators and centers' experience and performance is a huge difference. For example, the syntax trial, they analysis according to the different centers, the event rate is so different. So for example, left main PCI in the Hawaii hospital publication show that the low volume operators show that the higher rate of event. Recently, the European centers published similar data. So I think simple PCI, simple CTO intervention, I don't think that simple CTO
Exists.
Every CTO is not
Should
easy.
be respected, right?
So anyway, the more complex PCI should be done in the experienced hospital, high volume hospital by experienced doctors and operators. Or if the less experienced doctors, if they want to do something, then the senior doctors supervision is very important. That's your job.
Okay, now we will reverse for the second round the order of questions. Role of intravascular imaging in your complex PCI. what percentage of cases do you think that you're using, and do you think that this has increased over the years?
Yeah, frankly speaking, in some medical centers, almost all cases we use the intravascular imaging. So no doubt every CTO PCI, non-CTO complex, even simple lesion, we use the intravascular imaging. That's why our center's PCI outcome looks better than others. So
You had also a randomized trial that suggested that the IVUS-guided CTO PCI, the MACE at a year are much
that is the doctors in the several hospitals, doctors publish the data, CTO with the IVUS improve the patient outcomes. But I have a comment that I think the most important part of CTO intervention is after wire passage. Many CTO interventions spend a lot of time for wire passage. After wire passage, within 10 minutes, just stand, and finish the job. But it doesn't right.
No.
The patient outcome is associated with how to maintain the CTO patency, as you mentioned. Yes. So after CTO wire and passage, so we have to more attention to the how to optimize the stent result. So intravascular imaging, I think the pivotal role for optimizing stent implantation.
I believe you're absolutely right. In the beginning, at least, all the excitement was to cross, and then we thought that stenting is like. But the more we started learning from our failures, the durability of the procedure and the safety has become, at least in my opinion, more important than the acute success. So all this excitement about crossing, I think we should take a step back and make sure that we do a good PCI at the end of the day. Gerald, what are the studies needed to advance our understanding of the field and maybe to convince some of the naysayers? Is there a study that you have in your mind, I'm sure you think about these things a lot, that you would design to promote the field, and instead of downgrading every year the indications of the guidelines, finally we get it right somewhere in the middle?
Well, certainly we need solidification or more robustness of the data. The EuroCTO trial was too small in the population that we finally enrolled, so we need a trial of the similar idea to establish that the guidelines acknowledge that optimal medical and anti-anginal therapy is not as good as opening and clearing the lesion.
Do you think
I think the Nordic
the ischemia CTO, do you think it's going to answer that?
Hopefully will add some more data to that. This is one thing, but the greatest concern I have is that we are debating the decision-making on the syntax trial and the syntax score. And the syntax score is taken out of thin air using a factor of 5 for any lesion that is a CTO, upgrading the complexity of the lesions.
It's interesting. Excuse me for go ahead.
And this decides what should be done with the patient on a basis 15 years ago. Nobody uses the stent. The technique has improved. So what we actually need is syntax redone in the 2020s.
You know that we did it with Philippe Generoux, and it was almost accepted at JACCI, where we actually downgraded the 5+ that the CTO was giving, and it was accepted. And the very last minute, somebody intervened, and it was rejected. So we published it.
But we need to compare it in a similar fashion with Kambis.
Yes.
Because surgery is a handcraft, or it's a craft, as is CTO PCI.
You're doing it, right? As Professor Park just showed a trial design where on FFR basis there will be a randomization Kambis versus PCI, 600 versus 600 patient, definite trial, right?
Specifically for the diabetic patient. Only diabetic patient.
Only
not,
diabetes.
Yeah, not CTO
Not
patient.
CTO, yeah.
Paul, has the recent ischemia trial or revive changed, not your opinion necessarily, because I think you really understand the clinical trials, but have you seen a change in the referring patterns? Have you seen less patients or physicians, or even nowadays patients are very well educated. They go on the internet, they read. Has this changed at all recently, your practice and the discussions that you're having with your colleagues or your patients?
My feeling is that actually this did not change too much about the patient's perspective, but it changed the referring physician's perspective a lot. Because you see, patients may go online, look for the data, but I think it's the referring physician who is more influenced by this recent data, because they are, I wouldn't say they are not professional, but they are partially professional, but not as professional as we are. So like Gerald has stated out, sometimes looking at the trials should be very cautious. You don't just look at the conclusion. You have to understand the design and the flow chart
And the
of that.
population. And
Yes, and how the trial is conducted, and what are the patients selected, and who are the investigators involved. So I think as a CTO operator, what we should be doing is that we should communicate with other people more. You know, in the past, we used to communicate within our group of community.
we
talked
preaching
about,
to the choir.
yeah, we talked about device, we talked about techniques, we talked about difficult cases. But then I think it's time to step out and telling other people, we are not just a group of Frankensteins. We are the same PCI operators. We share the same feeling. We share the same philosophy as anyone who would to a stable coronary artery disease. I think so that people don't mistake us as anyone who is looking at a blockage and will open it no matter what, even the patient.
If you have a hammer, everything is a nail.
Exactly,
right?
exactly.
Kambis, we had an interesting brief discussion before, and I would like for you to elaborate if we have a couple of more minutes. Everybody is afraid of complications for CTO PCI, right? And there have been registries that show different rates of complications depending whether it's a CC committee or self-reporting and so on and so forth. You made a very interesting comment, which I have observed in my practice as well, and I'm interested in the opinion of the other panelists here. My high-risk PCI complication, non-CTO, as I think yours you mentioned before, has higher complication rate than my CTO PCI. You want to elaborate a little bit on this?
Yeah.
So when you do unprotected left mains with ROTA and occluded right and low EF and GFR of 30, and so you want to.
Yeah, actually.
Because I think there's a little bit of a misconception. I'm not trying to sugarcoat anything. I'm not happy. We need to reduce the complications in CTO PCI, but it's not that much higher than other subsets of complex and higher risk procedures.
Well, yeah, interesting that you mentioned that. I mean,
And can you speak up a little bit?
yeah, it's interesting that you mentioned that. Actually, I was also looking at this data, right? Personally, my personal data as well. And what I found out is that intra-hospital MACE is higher in non-CTO PCI in my arms, unfortunately, compared to CTO PCI. But, well, I was working many years in a high-volume center with a lot of referral patients. So what the CTO operator gets on the table, if it's a non-CTO, it's almost very, very bad. So we don't get the normal cases anymore. So especially when you work like you in Colombia or now in your new center, as well as me in the high-volume center. So, well, never published those data, but it was interesting to see. I was at first a little bit... let's say, shocked, or what's going on? Then I focused a little bit more into the detail. I saw the patients with MCS as well, and these were all stable angina, right, excluding acute coronary syndrome. But as a routine CTO operator, our MACE rate is quite not so high anymore compared to high risk PCI. So collaterals and CTO prevent us for adverse event. But if you go to, let's say, a very, very complex rotablation with aneurysma and subtotal stenosis and tortuosity, so you cannot predict, right? And this is also why we left the concept of putting stents in diseased grafts. Because we could not predict. This is why the CTO operators are open to native and have a very easy and safe procedure, almost the cases compared to high-risk intervention of the graft.
Paul, as Kambis said, as CTO operators, we are involved in the most difficult cases in the hospital, either to bail someone out or to actually do the case, even from our colleagues. Is this also your experience at your hospital?
Yes.
So
yes.
whenever a colleague calls you to do a case, he's not your friend?
Well, I still call them my friends, of course. But like you said, because we are almost like the safety net of the institution. So people will come to you to discuss with their most complicated case, complex ones. So CTO intervention is probably the pinnacle or the summation of all the PCI skills. So everything, you have to know everything. You have to learn everything until you embark on CTO procedures.
Sometimes I say that even if the CTO vessels were not 100% occluded, they would be very, very difficult vessels to treat, even if it was 90%. Gerald, do you think that as CTO operators, we should expand not only in, I don't call it stable coronary artery disease because it's stable until it's not. I like the term chronic. Rather than stable. Do you think that we should be the ones with a deep understanding of anatomy and physiology and all the things to actually take on the shock patients and be part of the new tendency, at least that we have in the US, to have a formalized shock or MCS program in the hospital? Do you think we are the ones who should be leading this area?
Well, I think that is depending on the institution. If you have very large structures in the institution, probably you need to make these formal decisions. And as Kambis said, I think and Paul, the CTO operator is the one that has really faced the worst cases. In an institution like myself, where we have 6, 7 interventionists, every shock patient is kind of treated by the community because we only have 2 labs. So we see the shock patient and we intervene if there is problems. It depends on the structure of the institution, and I would agree your notion that certainly shock patients can be very complex and you need to treat them fast and efficiently with all technical skills. So yes, I would say I agree.
I fully agree with your opinion because but I think the Interventional Cardiology Society is already very specialized society compared with other medicine. So I think we don't need to further division. So, but even though I really appreciated the CTO pioneers' job because CTO pioneers developed the device and technique and technology. I think it leads the advancement of whole PCI field. So CTO intervention leads the advancement of other CTO job, non-CTO PCI. So I think CTO intervention is, more actively involved with the non-CTO and education, sharing their experience with the less experienced the operators, I think.
Dr. Ran, what's the path for an interventionist in your center or in your country of becoming a high-level operator, chief operator, or CTO operator? I'm familiar in Europe and the US, but I'm not familiar if there's a specific path. How can you become from a good interventionist to an expert CTO operator? What's the pathway? Is that a formal educational process? Do you learn by proctoring? Do you learn by osmosis? Do you learn if you have a mentor? How does it work?
Maybe we did. Maybe we also have some proctorship, but a little bit different from the Western country and United States. Particularly, the we are a society just smaller than the United States and Western countries. So, usually the face-to-face direct education is the usual way to be a training method. So if you work for the big hospital, tertiary hospital, fortunately, like me, I think I have very, I'm very privileged to work for the big tertiary heart center because I have a higher chance to train myself. And I can see many good operators like for Dr. Kao visited my hospital very frequently before, so I saw many his excellent procedures. You visited here, the big conference, we can invite you come here. I will learn the very good experience and your lecture and knowledge. So this is how we develop our skill and our experience in Korea.
Okay. Any final comments or that you want to share with our audience and conclude this session? Like,
I think
look to the future or some final words of wisdom?
I think we already mentioned it. I think we have really to be careful regarding these new trials coming out, really to understand, like ischemia, or as you mentioned, also a revive, right? Because a lot of those patients revive, we would not treat anyway, right? With moderate stenosis in two vessels in a ischemia.
Not only that, excuse me for interrupting, but these are patients that were home and they were calling them and they say, you have a low EF. We have a treatment that may help you.
Without functional assessment. And so I think this newer area with functional assessment is a little bit different. We don't indicate them anymore. And ischemia is a very, very low-risk population group. And so regarding the question regarding the referrals, so I have a different point of view of what my referrals. If we say, well, this is a 70% stenosis and based on ischemia, we don't have to treat, let's put him on medical therapy. The referrals are calling us and say, please put a stent in, right? So because they are afraid and they are often traumatizing the patient. And the patient got also psychological affected. So I think there is a lack of interpretation how we should interpret those trials. Those patients that we see nowadays on the table, almost a severe ischemic cardiac heart disease with impaired LV function that should be still treated, in my opinion, whatever the guidelines say, 2A or so honestly. And the others with this low risk group, well, I think we treated them anyway conservatively all the time, right? I think which we are sitting here, we didn't treat any 70% diagonal branches, but we tried to open the huge dominant RCA because of symptoms, right? And I think this is the leading indication.
Paul, any closing comments?
Well, I had nothing to add, but I'm very grateful for this meeting because this is a great meeting. And after the pandemic, finally we can get together, have an in-person discussion. So I'm very grateful.
Gerald?
Thank you.
Yeah, I will follow up on Paul. I think we are here in a meeting and in a country led by S.J. Park, where there is really creation of evidence, even though we have our problems with the decision CTO, that is the design of the trial, confusing a little bit other concepts, but like the last IVUS, I think there is a lot of evidence created here, which helps us in guiding our therapy and improving our therapy. So we are all thankful to be here.
And I think, yes, Dr. No, just again, I want to thank for the hospitality and for the opportunity. And I see that we are, there were different schools of thought around the world, and we were debating sometimes silly things. I think that now, compared to 10 or 15 years ago, we are much, much closer in our way of thinking. And I admitted to Gerald that I've started doing parallel wires. After doing 12, 15 years of CTO work, I decided that parallel wire works. So I think we're coming much closer together to serve the common goal, which is to take good care of our patients. So I thank you very much. I hope it was useful for our audience, and see you at the next meeting.
Yes.
Thank
Thank you.
you.
Thank you.
Yeah.
Thank you.